Thank you, Professor Misbah, for your kind words. Respected chairs and audience, good afternoon. The topic of my presentation is NCD burning among young adults in the low middle income countries, Bangladesh experiences. In my presentation, I will share some of the experiences which we got from our first ever study that assessed the NCD burden among young adults in Bangladesh. So it was a joint initiative of the Non-Communicable Disease Control Program of Director General of Health Services, Ministry of Health, and the Center for Global Health Research, Diabetes Association of Bangladesh. Outline of my presentation. So we all know that diabetes and other NCDs already included in the 2030 Agenda for Sustainable Development Goals. And the objective is to reduce premature death from the cardiovascular disease, cancer, diabetes, coronary respiratory disease by 25% by 2025. Considering all these issues, NCD Alliance, International Diabetic Federation, World Heart Foundation, and World Health Organization call for simultaneous action on diabetes and hypertension for a more resilient health system. So now come to Bangladesh. According to NCD Risk Factor Survey 2018, NCD reported or contribute 67% of the total death in Bangladesh. But if you see the slide, the right hand, the study reported that 97% of the study participant had at least one NCD risk factor. Which are the NCD risk factors? The current tobacco use, consume less than 5 servings of fruits and vegetables, less physical activity, diabetes, hypertension, and overweight. The study also reported 8.3% diabetes and 21% hypertension. But if you see the slide carefully, the prevalence of the diabetes or hypertension is also high among the young age group. We also conducted a nationwide survey, and the sample size was 100,000. We cover almost the 95% of the country, and our study reported that 22.6% diabetes. But if you see, the good knowledge about diabetes is only 38%. It should be noted that the 34% of our national population is young adult, but still we do not have enough data related to the NCD risk factors. Considering all this, we conducted a study in 2021, and the aim was to assess the prevalence of the cardiovascular risk markers, including diabetes and hypertension, among the young adult population in Bangladesh, and its variation by the division, urban and rural location, individual level, socioeconomic and clinical characteristics. The secondary objectives were to assess the rate of the obesity, dyslipidemia, metabolic syndrome among the young adult population, to assess the both micro and macrovascular complications related to diabetes and hypertension in the young adult population, to identify the marker for the diabetes hypertension following different anthropometric indices, and to develop the country-specific cutoff level for anthropometric indices including BMI, waist circumference, waist hip ratio, and neck circumference. And finally, to investigate the serum lipids, including total cholesterol, triglyceride, LDL, aged separately and in combination, and their association with diabetes and hypertension. So in this study, 2,468 young adults aged 15 to 35 years participated in this study, which conducted from 28 August to 20 October 2021 in 8 urban and rural areas of Bangladesh. We used multi-stage cluster sampling techniques for selection, and we also used the population percentage of each division following the census of 2011 for sample distribution. We use semi-stage questionnaires and face-to-face interview for data collection. This map is showing the whole Bangladesh and our study areas. Inclusion criteria included permanent residents of both genders, age in between 15 and 35, which I already mentioned, being able to communicate, willing to join the study. Age less than 15 years and more than 35 years, taking medications known to alter oral glucose tolerance test, unable or unwilling to give the informed consent or communicate with the study staff, and pregnant women were excluded from our study. We followed the WHO step 1, 2, and 3 procedures for collecting the study variables. And study variables included socioeconomic variables, anthropometric variables, clinical use blood pressure, vascular use, we used the peripheral pulses, peripheral neuropathy, we used 10 gram monofilament and 120 Hz tuning fork. We used very first time the artificial intelligence for grading the diabetes neuropathy, and we used 6 liter ECG. And biochemical variables include fasting blood glucose, 2 after blood glucose, HbA1c, fasting lipids, urine album creatine ratio. And this is the very first time we use point of care. This is the whole the study plans we used during our study team, and the portion of the participant. Professor Azad Khan was the principal investigator, and Professor Akhtar Hussain, President IDF, and myself was the co-PI. So now I will share some of the key findings, starting with the socio-demographic informations. In our study, the urban participant and female participant were found slightly higher than the rural and the male participant, and half of the participants were less than 20 years. And if you see, only less than 1% participants were no educations. So mostly at least had the secondary and college and above level of educations. 87% of the participants belongs to Muslims, and more than 80% belongs to middle and high income group. Now come to the family history. Almost 42% participants had family history of diabetes, 43% had the hypertension, 20% coronary artery disease, and 70% cerebrovascular disease. But if you see, more than 50% participants are sedentary. Now come to the obesity. The prevalence of the obesity defined by the BMI at or above 25 kg per meter square was 26.5%. And the prevalence increased with increasing age, which was lowest in the 15 to 19 age group, which was 18.2%, and found highest in the 30 to 35 year age group, which was 55.1%. We did not find any gender difference related to the prevalence of the diabetes, obesity. However, the prevalence was found significantly high in the urban population. Now come to the abdominal obesity. Prevalence of the abdominal obesity was 26.1%. Like the general obesity, prevalence also increased with increasing age, which was found lowest in the 15 to 19 age group, was 16.8%. But if you see the 35 to 35 age group, which was 60.6%. Prevalence was found significantly high in the female age group and the urban population. In our study, almost 71% participants had both general and central obesity. Now come to the diabetes. Prevalence of the diabetes was 7.4%. Prevalence was found slightly higher in the females and in urban population. And prevalence was found lowest in the 15 to 19 years age group, which was 4.4%. But the prevalence was found significantly high among the 30 to 35 age group, which was 21.3%. But if you see the slide, 61% participant remained asymptomatic. Among the symptoms, general obesity was found highest, followed by the increased urination, increased thirst, increased hunger, and weight loss. However, 22.5% participants had more than 2 or above symptoms. Now come to the hypertension. Prevalence of hypertension was 13.5%. Prevalence increased with increasing age, and prevalence was found higher in the male and in rural populations. Like the diabetes, almost than 60% participants remain hypertension. Among the symptoms, headache was found higher, then followed by the neck pain, blood vision, tiredness. However, around 27% participants had more than 2 or above symptoms. Now come to the lipid disorder. Prevalence of the high cholesterol was 11.2%, high LDL cholesterol was 16.7%, high triglyceride was 17.8%, and the low HDL was 87.8%. Prevalence of the dyslipidemia defined by the high TG and the low HDL was 15.8%. Like the other variables, prevalence also increased with increasing age. It was lowest in the 15 to 19 years age group, which was 9.9%, and found highest in the 30 to 35 years age group, which was 37.4%. Prevalence was found higher in the male, which was 20%, and in urban population, which was 16.6%. Metabolic syndrome, defined by the ATP3 definition, which was 23.6%. Prevalence was found lowest in the 15 to 19 years age group, which was 15.6%, and like others, prevalence found highest in the 30 to 35 age group, which was 57.1%. Prevalence was found higher in the male and in urban population. And we have found a significance in the geographical differences in different variables of the cardiometabolic risk factors. Now I will share some of the findings related to the daily dietary habits. Almost 100% participants eat rice, and almost 70% participants eat rice 3 times daily. Roti and chapatis 62%, fish 31.7%, meat 8.4%, egg 32%, green vegetables 61%, fruits around 25%, soft drinks 17%, fast food 15%, and extra salt is almost 74%. And soybean was found the most consumable cooking oils in our study. In our study, 92.3% participants had at least one NCD risk factor, which in line with the another step survey conducted in 2018. We also checked the association between the atherosclerotic disease and diabetes and hypertension. In our study, waist circumference and waist hip ratio have shown a significant association with diabetes, and however, waist circumference and BMI had shown significant association with hypertension. We also checked the association between blood lipids and diabetes and hypertension. In our study, LDL cholesterol and triglyceride have shown significant association with diabetes and hypertension. This is important findings we found in our study. We also checked the sleeping hours and their association with cardiovascular risk. In our study, we have found less sleeping, that is less than 7 hours, had significant association with diabetes, metabolic syndrome, and central obesity. In our study, we also checked the complications. Rate of retinopathy was 4%, albumin 2.5%, neuropathy 30.8%. 30% participants had tachycardia, and 4.5% had atrial fibrillations. But if you see the slide, retinopathy, albumin increase with increasing age, but the atrial fibrillation and tachycardia decrease with increasing age. Now come to the conclusion and recommendations. Our study revealed a high prevalence of cardiovascular risk factor, including diabetes and hypertension, in urban and rural Bangladeshi young adult population. More large-scale studies with control population, including all the possible influences, are required to confirm our findings. Early detection of the cardiometabolic risk factor is likely to be cost-effective, as timely initiation of treatment will prevent complication, thereby reducing the cost and unnecessary suffering both for the individual patient and society. Ensure affordable access to fundamental care for people living with diabetes and hypertension. Considering local contextual factors that may influence policy implementation, such as political support, resource allocation, availability of the local data for monitoring impacts. I am ending with the good news, which already shared by the Professor A.K. Azad Khan. She is our Prime Minister, and the Prime Minister of Bangladesh, Sheikh Hasina, nominated as the first IDF Global Ambassador for diabetes. Thank you.